to learn things. And remember one thing, that learning and then keeping the knowledge also is important. So it doesn't matter how much we know, if we don't keep looking at it and practice it, it goes away.
Yes, sir.
So I will show some ECGs and we'll have question. Do we have the poll? And I would request there are 62 participants, except for the faculty. I would like everybody to answer whatever.
Mr. Kamrul, please arrange the poll.
Yes.
Keep the ECG for sir 20 seconds.
Yes. So while they're doing it, there is Naruma, there is a question from Dr. Manoj Koirala. RBB due to conduction defect versus RBB due to atrial septal defect. Is there any difference?
In ASD, it was due to stretching effect due to volume overload. And RBB, there when the pathology in right bundle branch block, the physiology will be different. But
Okay.
the findings in ECG is same.
So we'll have to look at right axis, left axis, and clinical feature, right?
Yes, sir.
To correlate. And there is another question that Dr. Arif Hussain said, how frequently should we do ECG in ASD for arrhythmia?
Sir, in ASD, every patient should be done ECG when during follow-up, because I told sir there is hemodynamic changes occurs, and the QRS changes that I have shown the magnitude of the shunt. So it should be means in ASD small shunt we usually give 6-month follow-up, and it also depends upon the symptom. And if the symptom develops and it is the significant magnitude shunt, then we give short follow-up like 3 months. And sometimes we also have to give, if severe pulmonary hypertension comes in 2 months or 1 month, even after 15 days we give follow-up. It depends upon the severity, symptom, age of the patient.
Good, thank you. Did we show the poll, start the poll? Or we don't have it? Okay, good. Okay. So we have all the answers here. I'm going to start with the last one, ventricular paced rhythm. So if you look at lead 2, you can see that there's a P wave and there is a QRS complex. And before the QRS complex, there is no pacing spike. So it's not a ventricular paced rhythm. And let's start with number 1 then, sinus rhythm with left atrial enlargement. Sure, if you look at the V1, it looks like deep, wide wave in lead 1, but lead V1. However, before each P wave, there is a pacing spike. So it's the atrial paced rhythm. And with atrial paced rhythm, I hesitate to diagnose left atrial enlargement or atrial enlargement because it depends on the pacing lead. Now, the third will be dual chamber paced rhythm. There is an atrial pacing spike that I can see, but I don't see any ventricular pacing spike. So maybe this is a dual chamber pacemaker, but with this ECG, my diagnosis will be atrial paced rhythm. The other thing that I did not put, when you put that diagnosis, also look at the QRS complex, because QRS complex is conducted and looks like normal QRS. You have to mention that in your report. Thank you.
Sir, should we start the poll?
Yes, please.
Kamrul, start the poll for 30 seconds.
Okay. So some sinus rhythm, one person physician said, and then ectopic atrial rhythm. Sure, these are all reasonable choices because there is a P wave before each QRS complex, and the P wave looks funny in lead 2-3, and that gives the possibility of ectopic atrial rhythm or sinus rhythm with left atrial enlargement. However, it's a little difficult to see, and there is no E, but I'm sure that's D. But if you look at this, I have enlarged this ECG. You can see where my pointer is in V1, there is a small pacing spike. And a lot of the new bipolar pacemakers will have that problem that the pacing spike is very small. So I've enlarged lead V1. You can, when I magnify this lead V1, you can see that the pacing spike much more clearly. So you have to pay meticulous attention. And if you have doubt, then you look at the clinical history of the patient. That look, by the way, does this patient have pacemaker? There is no magic wand that I find out this ECG. A lot of times I just investigate. I see something, I think it is a pacing spike. And the other thing is that, can it be an artifact? If it is an artifact, it will not be present in every QRS code. So you can see where my pointer is. There is a pacing spike. There is a tiny one here and tiny one here. So it has to be consistent. Otherwise, it can sometimes be artifact. How about this one? I think I'm going to go over this quickly. I mean, again, this is the same pattern. It's a little bit more clear. You can see in lead V1, there is a tiny pacing spike. It's so small, it's difficult to see. And that's why you have to pay attention. So when I magnify this, you can see this. I have magnified V1 and V2, and you can look at the pacing spike. And then you look at...
Sir, that means the clue is that abnormal P wave.
Exactly. Abnormal P wave, and then this sharp, which can be an artifact, but if it is so sharp and always present, it cannot be an artifact. So just pay attention to this. Okay, this one, I want the poll. This one. Okay. So this is interesting. Anybody wants to comment from the faculty on this ECG, or do you want me to do it?
Wadud sir. Wadud sir, I request Professor Wadud Chaudhary sir to make a comment.
So I'll talk about it. So if you look at the rhythm strip in the bottom,
whether it's only atrial pace rhythm and voltage criteria, and by voltage criteria, look at this. With V5 or V6, it doesn't fulfill the voltage criteria. But in case of AVL, no, it's also 10 millimeter only. It doesn't fulfill as well.
How about lead 1?
But lead 1 is tall. That's the problem.
Yes.
Sir,
So
may I ask one question?
Sure.
Sir, may I
please
ask?
do. Yes.
So is it that the ventricular pacing spike is falling on the R wave?
So
That's the certification.
that's
Yeah,
the whole
Diffusion.
point.
Yeah.
Yeah.
that's the certification.
So this is the question I designed. I said sinus rhythm with left ventricular hypertrophy by voltage criteria because lead 1 is tall R wave. But it is not sinus because there is a pacing spike
Yes.
for each P wave. So it's a It's not an ectopic atrial rhythm. So it is atrial paced rhythm with voltage criteria for left ventricular hypertrophy. Or now, if it is left ventricular hypertrophy with voltage, look at lead AVL. My first complex, there is a tall R, but second one does not have one.
Yeah,
So,
significant. Yeah.
and also, as Jamil pointed out, that look at lead one, it looks funny looking R wave. It looks like a sharp line drawn on the QRS. So basically, it's a dual chamber pacemaker with a pseudo fusion. That means there is a ventricular pacing spike, but it did not capture. It just gave a wrong impression of high voltage. Thanks, Jamil.
And another point I'd like to make, look at the rhythm strip 2. You see that one is different than the other ones.
Yes. So look at this is taller, this is short.
Yeah.
So the pacing. So, so this
Also,
is
V5 shows some are the bigger, some are smaller.
Yeah,
Exactly.
Mhm.
So remember that the signal, how it looks, it doesn't look like an R wave in lead 2. It looks like a straight line drawn on the R wave. So those are the things that you look at. Thank you. So it's pseudo fusion means there is a pacing spike, but it did not capture the ventricle. It just conducted QRS complex. And this is the same patient when it is not pacing. It's just dual chamber, sinus rhythm with conducted PR interval. So this is an ECG. The reason I put it, this is a ventricular paced rhythm. I did not put a question in it. Let's see if I have a question. No question on it. But when you report this, you have to report the underlying rhythm.
Yes.
Is it sinus or is it atrial fibrillation? And it is
Atrial
so
fibrillation, yeah.
Yeah, it is so important because if this patient comes to me and I find this ECG, then we have to raise the issue of anticoagulation and management of atrial fibrillation, even if the person is asymptomatic. So anytime you have a ventricular paced rhythm, look at the underlying rhythm. Is it sinus or is it AFib or atrial flutter or is it something else?
And one point I'd like to make, this type of ECG, computer reading will be just V-paced rhythm. Computer will not tell you atrial fibrillation underlying. So make sure you don't miss it.
Absolutely. Our computer will not tell you that. So how about this one? This is a bread and butter ECG. So I hope everybody will be doing it correctly. Yeah, so majority answered, and both C and A are correct because it is, of course, ventricular paced rhythm. But before each QRS pacing spike, there is a P wave with a consistent relation. So you have to describe that. And if you describe, whoever answered ventricular paced, if you take that P wave before each QRS complex, which has constant relation, that means it is sensing the P wave pacing the ventricle. So the correct answer is atrial sinus ventricular paced rhythm. Accelerated idioventricular rhythm is an option, but there is a pacing spike before each QRS complex, and that takes it away. And it is not sinus rhythm with bundle bunch block because pacing spike is very, very clear. Now, of course, if I had just lead V2, we can confuse it, but with the other leads, we cannot. Okay. Okay. Sure. Wadud?
না স্যার, এটা ওই যে খুব ভালো করে তাকালে ছোট স্পাইক গুলা দেখা যায়,
Yes.
কিন্তু এর যেটা হলো যে তার পিয়ার ইন্টারভ্যালটা খুব শর্ট মনে হচ্ছে।
Yes.
V1 এ দেখতেছি আমি এটিএল স্পাইকের মতো,
Yes.
V1 এ তা দেখতে পাচ্ছি, কিন্তু অন্য
এক্ষেত্রে কিন্তু
জায়গায় গুলায়
পেয়ার ছোট না।
পাচ্ছি না। তার মানে এটা আসলে এভিসিকুয়েন্সিয়াল পেসিং।
Yes.
Yes.
So I have magnified V1, there is a pacing spike, and the V2, the ventricular spike is very difficult to see, but V4 you could. And Wadud mentioned something always. Lead 1 looks like left bundle, but from V1 to V4, there is QS pattern. It's very, very unusual for that to happen unless the lead or independent. So this is efficient. So again, I put these two ECGs next to each other. Keep an eye on it. The computers will make mistakes. We will make mistakes, but it is our job just to make sure that we look at these ECGs carefully. I'm going to skip this one and then skip this one. Okay, this one.
Mr. Kamal, give the poll, please.
Yeah, so majority answered correctly. And B is also, B is not correct because there is always atrial pacing spike before each QRS complex. So what's happening here, if you look at the PR interval here is long, and then gradually it gets short. And a lot of these new pacemakers are designed, you don't program this feature in patient with complete heart block. If somebody has sick sinus syndrome, you want to program this feature so that you minimize ventricle. You can see that here, atrial pacing, ventricular pacing, the interval is short, and then the pacemaker makes it long to see if the conduction comes out. And this is PR long, PR long, PR long. And then after a while, you say, oh, I'm not seeing any ventricular conducted beat. I'm going to make it short. And it is programmed in this way. And then after a little bit, again, it will search. Now, this feature, as I told you, that it should be programmed in places where you want to minimize the ventricular pacing and you believe there is AV conduction. Otherwise, you don't want to program this feature. This feature, any feature in a pacemaker, waste battery. Even if you save 1 month of battery, it's important. So features that are not necessary should be turned off in pacemaker programming and make the pacemaker simpler. Thank you.
Sir,
Yeah.
there's a question, sir. Why
Yeah.
there is RBB pattern in the ECG? In V1,
Oh.
there is a, so can it confuse the,
Yes. Yes. I wonder if there is a degree of fusion. I don't have the baseline ECG on this patient. Is because the QRS is relatively narrow. The other possibility, whether it's a biventricular pacemaker, I don't think this was a biventricular pacemaker. It was a regular pacemaker.
that's interrogation shows that is a dual chamber pacemaker, but still the V1 shows the RBB morphology. That's the
Yes, you're right. Absolutely. No, don't put any poll for this one. I'm going to skip this one because we're a short time. This one, yes.
please put poll.
Yeah, and please carefully look at this ECG before when you answer. One person answered sinus rhythm Weinke by V block, but if you look at the QRS complex, I put it just to make it confusing. There is no Weinke bar because there is no irregularity in the RR interval, number one. Number two, there is no drop beat. So that's why it's wrong. And dual chamber pacemaker, normal pacemaker function is a possibility, but I'm going to come to that. And then dual chamber pacing, atrial failure to capture. So what I did is let's expand this thing. There is an atrial pacing spike and there is no P wave. So clearly there is failure to capture the atrium. Sometimes you can see it if there's a P wave just before it, but this one, there is a P wave and it pays the atrium. That means it did not see this P wave. So there is failure to capture, failure to sense. Now, this P wave, there is this atrial pacing spike, there is no P wave. By this, I cannot tell that there is failure to capture because there is a P wave and if it paces immediately after the P wave, it can be refractory. So this one tells me there is failure to capture the atrium, and this one tells me there is failure to sense the atrium because it should not have paced here. It should have seen this. And the other part, sensing part, is that if we do it sensed it, it would have paced the ventricle synchronized. So it is not seeing the P wave at all. And this is a random probably because this P wave and this P wave looks like just random atrial pacing. I don't believe this. Again, you can see this one did not capture. Any questions from anybody?
One question I have, that if the P wave, like we call blocked P wave, just immediately after the V complex, and that might fall into the blinding period, right? And atrium might not sense that.
Okay, so what Aziz is mentioning, blanking period. Now, blanking period is designed to make the pacemaker blind for a very brief period of time. And it is usually between 40 to 80 milliseconds, not more than that. So if that was true, then it would have been over here. If it didn't see any P wave over here, it can be a blanking period or within the atrial refractory period. But this is way outside. This is about 400 milliseconds outside. So this is not in the blanking period time.
Sir,
Sir, I have a question.
Yes.
This patient, if he has good LV function, should he not make it VVIR?
Well, the question is, how old is the patient? 70-year-old. And patient, depending on how old this lead is, number one. If it is a newly implanted pacemaker, definitely I'm going to revise it. Number one. Number two, let's say 70-year-old comes to me totally asymptomatic, and the pacemaker, there is 2 years of battery left. What I may do, I will tell the patient, look, I know the atrial lead is not functioning, ventricular lead is working, you are doing well. Let's wait until the battery runs out. And at that time, I'm going to put atrial lead in, new atrial lead. So that's an option. And the third will be, you can make a decision, clinical decision after discussion with the patient. Look, just leave it VVI. And patient will do fine.
Lead to extended life.
Yes, exactly. But at that point, I'm going to program it VVI.
Yeah.
Instead of DDD, because then it is going to waste battery for nothing.
Sir, my question is that many a times we don't see clearly the P wave following pacing spike, especially atrial activity may not be very much evident following spike.
Yes.
So can we certainly say that the atrial capture is lost or the atrial thing is lost?
Sure. The question is, if we don't see it, then I have to find a lead where I can see the P wave, or do a double strength, double gain, and you'll see the P wave. It is very, very unlikely that you will not see P wave in any of the leads. So if you don't see any P wave, then you can see, sometimes you can see little bit of undulation of the straight line. Look at this line, how flat it is. Sometimes you'll see a little bit of wiggly line, and if you magnify it, you will see that it looks like a P wave. That's different. But to see a flat line, it is almost impossible.
Okay, thank you, sir.
Thank you, sir.
So okay. So I'm putting one more.
এই পোলটা একটু পরে দাও, সবাই দেখুক, তারপর পোল দাও।
So this is better. I think both C and D. C is partially correct. I'm going to enlarge this ECG. Look at this. So if you look at this one, I don't think there is any capture. But over here is different. There is a P wave. So it's intermittent capturing in the atrium, number one. This one did not capture. This one did capture. Here is sensing failure. Now, one possibility that Aziz was mentioning, there is a P wave. It is possible that maybe there is a blanking or something happened and he did not see that. And timing, or the pacemaker already made a decision to pace. But this one, clearly, there is a P wave, but still there is an atrial pacing spike. Now, how do I know it's atrial pacing spike? Because atrial pacing, ventricular pacing would have captured it because it proved in the very beginning that it is able to capture the ventricles. So basically here we have intermittent failure of atrial capture and sensing failure. Now, two issues. One, why is it failing to capture the atrium? Maybe the output is not set right. Maybe the threshold is not good. Same with the P wave, that sensing, maybe the sensing amplitude of the P wave is 1 millivolt and I put the sensing at 1, it's not sensing it. So we can reprogram it. Or maybe just it's totally malfunctioning, the lead. And so you have to do a detailed programming of this device. And I'm going to, this will be the last one, that this will be interesting ECG to discuss. Let's look at it and then we'll talk about it.
Mr. Kamal, please put poll.
এইটা পারা উচিত
না, কোথায় পাকিস্তানে এরকম
Okay.
Mhm.
Yeah, so interesting. And I have a reason to put the sinus bradycardia with marked first degree AP block. Question is, if you look at this, you see that atrial pacing, and then there is a ventricular pacing and no capture, and there is a QRS complex. And I timed it. This P to R interval is constant. I think these are conducted. So there is marked first degree AP block and with failure to capture. Now the question is, why is it pacing like this? There are two types of timing in the pacemaker. One is atrial driven, one is ventricular driven. I'm assuming that this pacemaker is set at a rate of 60. And if you look at where you can see my pointer, right?
Yes.
Yes, so pointer 1, 2, 3, 4, 5. That's 1 second, 60 beats per minute. If this pacemaker is set at 60 beats per minute, the R wave triggers the next cycle and calculates that the ventricular pacing should be here and then preceded by the atrial pacing. So this is a ventricular timed rhythm. And there are other type of pacemaker which does both or atrial time, and depending on the manufacturer. So that's why the timing is like this, that it is pacing AV. Otherwise, you would have assumed if it were triggering from this, the atrial pacing would be after 1 second. But no, atrial pacing was earlier. It is a ventricular timed pacemaker. And same thing can happen like VDD pacing or DVI pacing. Thank you. I think this is, so again, what is the etiology of this?
রবিক ভাই,
Yes.
যখন পেসমেকার দিচ্ছে তখন ওইটা ইন্টারভিউ গুলো চেক করে দেয় নাই যে এটা অ্যালাউ করতেছে এত prolonged heavy delay.
Oh, no. Because it is failure to capture.
Oh, that's why. Okay, so that's I'm happy with that because
Yeah, it's a failure to capture.
এটা
But-
V1 এ
okay.
স্যার
That's
V1 এ ওই
reassuring.
পেসিংটা দেখা যাচ্ছে।
Yes, so
V1 এর পেসিং স্পাইকটা দেখা যায় ভালো।
Exactly, pacing
Failure
spike.
to capture.
So the problem is that my question was, why is it pacing here? Why not a little outside? It should have been 1 second from here. But the ventricular timing is correct. And it is a ventricular base. And so why did it happen? One possibility is just that the threshold has increased. Number one, that maybe the pacemaker is set at 2.5 volt and the threshold is 2.7 volt. So we can change the pacemaker program. Or maybe the lead, it is a new pacemaker, lead has moved.
Yes.
In that case, you have to reposition. It will still give a pacing spike. So these are the two positives. It's not a fracture. If it is a fracture, then you will not see any pacing spike. And I'll show you one, this one. This is a patient who had a dual
So
chamber
Rafique bhai,
pacemaker. Yes.
number 3 is correct answer, right?
Yes, number
Failure
3.
Yeah.
Exactly. Exactly. So this is the other one. Look at this. This is a patient with dual chamber pacemaker comes with syncope. And then there is P wave, but there is nothing after that. And there is atrial pacing also. This pacemaker basically is not delivering any spike after the P wave. That means this was a patient with RV lead fracture. If there is a fractured lead, you will not see any signal at all. And it was programmed appropriately. Thank you.